Right. So in this particular presentation, we'll look at the digestive system, looking at the first part of the digestive system. So that covers the introduction and the first part, which will be the oral cavity and probably the esophagus as well. So digestive system is a system that prepares raw food into units that the body can absorb and then distribute to all parts of the body. So it involves a series of tubes which undergo some changes in certain parts of the body. So this tube begins from the head region there in the mouth, running through the neck region, which is the esophagus, running through the thoracic region, which is the esophagus again, then entering in the abdomen, esophagus. Then in the abdomen, we have continuation of that tube as the stomach continues as the small intestine, which is here. Of course, the small intestine is divided into those three parts. The first part being the duodenum, second part being the jejunum, the third part being the ileum. Then continues as a large intestine. So undergoes some change, the diameter increases and certain surface features also changes. Now it's called the large intestine, of course, divided into the following. That is ascending, first cecum, the first part is cecum. Inferior to the cecum is a vermiform appendix, then ascends as ascending colon, then cuts across as transverse colon or horizontal colon, if you like, then descends on the left side of the abdomen as descending colon, then makes this S-shaped region in the inguinal region as sigmoid colon, then later on forms a rectum in the pelvic region and exits as anal canal guarded by the anus and its sphincters. In addition to that, we have other supportive organs, including 6 salivary glands. So that is 3 on the left, 3 on the right. That is parotid gland, submandibular gland, and sublingual gland. In addition to that, we have small glands found in the esophagus. Then we are adding the liver, which is actually or essentially the largest organ inside the body. Then we have the pancreas there, posterior to the stomach is the pancreas. Then on the undersurface of the liver, inferior surface of the liver is the gallbladder. So those are accessory organs: salivary glands, liver, pancreas, and gallbladder. Okay, so let's look at some of the essential parts of the digestive system. So saying it runs from mouth to anus. In addition, we have accessory organs, which I already mentioned. Let's look at the 5 processes through which food undergoes in this digestive system. So when food will pass through 5 processes in the digestive system. The first one being ingestion. So this is a process by which food is introduced in the digestive system or digestive tract, mainly via the mouth. Okay. So introduction of food in the mouth is called ingestion. Thereafter is followed by propulsion from the mouth to the esophagus, esophagus to the stomach, stomach to the intestine, and on like that. Now be reminded that in the oral cavity, there will be breakdown of food particles into smaller particles. Those particles cannot be absorbed yet. It's just mechanical digestion. At the same time, there is chemical digestion that takes place in the stomach, in the mouth. So before we even go to propulsion, as food is being chewed, food is mixed with saliva from those 6 glands we have talked about. Then, as food is being mixed, the teeth are grinding the food. That is mechanical digestion. Then in the saliva, there is salivary amylase, which begins a breakdown of carbohydrates into their monomer units. And then propulsion follows. Then later on, we have digestion now in the stomach. So in the stomach, physical as well as chemical digestion continues. So in the stomach, we call it churning, while in the mouth, we call it chewing or mastication. So churning occurs in the mouth, where churning occurs in the stomach, whereas mastication occurs in the mouth. Both of those processes are physical digestion. Then chemical digestion progresses in the stomach. So there's initiation of breakdown of protein as well as lipids. Thereafter, food is channeled to the small intestine where absorption takes place. So absorption begins in the stomach, then continues on in the small intestines. So much of the nutrients are absorbed in the small intestines. Then fluids, some vitamins, and other micromolecules are also absorbed in the large intestine. Thereafter is elimination. So once all the useful elements have been absorbed, what remains is waste. The body cannot use it, or rather doesn't have the necessary chemicals or enzymes to digest, and therefore that has to be eliminated as fecal matter. Those are the 5 processes under which food goes through in the digestive system. We now look at the structure of the digestive system. So we call it general structure because at the end of the day, the digestive system is just like a tube running from mouth to anus. So we see that this tube has layers or coats, if you like. Let's take a look. So I'll use the diagram here to explain that. Let me find a better one. Okay. All right. So that is a tube itself. So start from inner layer going out. So these are the following layers that you're going to find. We're going to find mucosa. Let's go to this one, which is a bit more general first. So inner lining here is mucosa, as shown. Then there will be submucosa. Okay, so submucosa there, then followed by 2 layers of muscle. We call it the mesenteric layer. Okay, now this mesenteric layer or muscularis layer, we're saying it has 2 layers of muscle, inner secular and outer longitudinal muscles. So secular are going around the tube like that. Then longitudinal are following the long axis. So they're running from mouth towards the anus, whereas the secular are going circle around the tube. Then the outermost layer is connective tissue known as serosa or adventitia, depending on which level of the digestive system you're looking at. So if it's a part of the digestive system that is located above the diaphragm, the outer covering is known as adventitia. Anything below the diaphragm, the outer covering is called serosa, because in the abdomen, all the way into the pelvis, we have peritoneum. So the peritoneum covers the outer part of the digestive tract, and therefore we call it as serosa. But we don't have peritoneum in the chest and in the neck region. So we call that outer connective tissue covering as adventitia, but the function is the same and structure is similar. So this structure here is a bit more detailed than the previous one. So we'll see that much of the inner lining, what we're calling the mucosa, is highly folded. I'm sure you can see those, folds, more like hills and valleys. Okay. Then what we are seeing here is a layer of submucosa. Now remember that submucosa is nothing but loose connective tissue. And we agreed when we're discussing loose connective tissue to say this is a tissue where it is highly supplied with blood vessels. Fewer fibers, fewer cells, but more ground substance and more blood vessels. So that is a second layer. So you find this throughout the digestive tract. So here it is called lamina propria. Lamina propria. This layer is lamina propria. Okay. Now, after submucosa, what we have are now the two layers of muscle. So that is the inner circular going around, then the outer longitudinal muscle. Then the outer covering, again, is another connective tissue, another loose connective tissue there, which we're now referring to as adventitia or serosa. In addition to that, in the submucosa, apart from having high supply of blood vessels, we find that there are also nerves. So those are nerves. So since they are found in the submucosa, they are known as submucosa or Meissner's nerve plexus. Meissner's nerve plexus. That is the correct spelling here. Meissner's nerve plexus. So Meissner's nerve plexus is found in the submucosa. Then the one found in the muscle layer. Remember the muscle layer, we're saying there are two. There is inner circular and outer longitudinal. So in between those muscles, we find another set of nerves as shown here. So we call that as the myenteric nerve plexus or the way back nerve plexus. That is way back nerve plexus. So the two sets of nerves, these are network of nerves, collectively are known as the enteric nervous system. The enteric nervous system, some books will say this is the brain of the digestive system. So in short, the digestive system has its own nerves which control motility, what we call peristalsis, movement of substances from one region, for example, from the stomach into the small intestine, from the small intestine into the large intestine. All that is controlled by these nerves. For example, prolonged exposure to certain types of drugs, especially those drugs that cause, artificial diarrhea. Okay. What we call purgatives. Okay. Am I correct? Purgatives, huh? Yeah. They may cause damage to these nerves, and therefore, person loses control of their bowel motility. Motility is simply movement. Okay, so either this person will develop constipation or what we call paralytic ileus. So together with the nervous system now, this enteric nervous system controls how fast or how slow food will move throughout the digestive system. And that is why when someone is administered with what we call general anesthesia, these nerves relax. They are no longer function. They go to sleep until that drug is removed from the system. That's when the alimentary canal will begin to function again. So you have to wait for that. If you feed the person before that occurs, chances are that that person will have paralyzed intestine, paralytic ileus again. Okay. So generally, that is what you are going to see throughout this tube. There will be mucosa, which is made up of different type of epithelium. In the mouth, it will be stratified squamous epithelium, non-keratinized. Same with the esophagus. But in the stomach, it will be simple columnar epithelium. All the way to the anal canal, where it again changes to now stratified squamous epithelium with keratin. So the epithelium in the stomach, small and large intestine is the same, and also the rectum. But in the anal canal, it changes again. So you see that we are starting with stratified squamous epithelium in the mouth. We're also ending with stratified squamous epithelium in the anal canal. Then in between is simple columnar epithelium. So generally, those are the four layers we're looking at: mucosa, submucosa, muscle layer, and serosa or adventitia. So we must keep this in mind as we go further in our discussion. Okay. So that being said, we now have a brief discussion about the oral cavity. Oral cavity is nothing but mouth. You can also call it buccal cavity. So this cavity is guarded by the two lips, upper lip and lower lip, or we can alternatively call them labias. So labia in anatomy means lip. So there's upper labia and lower labia here. Okay. Then we're saying this lip has two zones. Okay. You can see this person, the lip was open. So inside the lip there, what we have is membrane, what we call mucous membrane. So mucous membranes at any given time must have fluids on their surface. In short, they must be kept wet or moist. Okay. Then outside the lip is skin. So that's how the lip is. You can see here, this is skin. Inside is membrane, mucous membrane, or mucosa if you like. So here, even if it's drying outside the lip here, even if it's exposed to heat, drying, and the rest, it will not have any effect. But membranes inside there, when fluid in the body reduces, these begin to crack up and form sores. Then we have a border now between the skin outside and the membrane inside. This red part here, or pinkish. In Africans like you and I, it can even be, darkish or brownish in color. It doesn't really matter. Okay. Now, this part is called the vermilion border. Vermilion border. It's an important transition point because at that level, it is neither skin nor membrane. So it is simply vermilion border. So outside the lip here, where there's skin, you're going to find hair follicles. If it's a man, you even find beards here. This is still part of the lip. The lip extends all the way down to the chin. That is still a lip, mind you. So there will be beards here if it's a man. Then this part is a vermilion border. Then inside is membrane. So since it is skin, we expect there will be sweat glands and sebaceous glands. Then membranes, a lot of blood vessels there, and also some minor glands there that secrete some fluid to keep this membrane moist. But at the vermilion border, there are no glands. So this part is naturally made to be dry because it lacks glands in form of sweat glands, sebaceous gland, and mucus glands, which are found in the membrane part of the lip here. So this part is subject to drying. So if you're speaking for some time, you find that your lip begin to stick to each other because the vermilion border becomes so dry. Okay, that's why unconsciously, sometimes even consciously, we tend to lick on this part so that it's kept moist to avoid cracking up. And females, this is where lipstick is applied. That part is known as vermilion border. Now, the space between the lips is called the fissure, oral fissure. So oral fissure can be open or oral fissure can be closed. So when the two lips meet, then we say the oral fissure is closed. When the two lips part, then the oral fissure is open. You can see what is inside the mouth. Before I leave the lips, there's one more structure of importance known as a labiofrenulum. You see that part here? This is connective tissue. So a frenulum in anatomy is an anchoring structure. It's a structure that is attaching one structure to the other. So whenever you hear frenulum, think of that idea. So the labiofrenulum, there are two, upper labiofrenulum and lower labiofrenulum. These frenulum hold the lip in position. So they connect the lip to the gums so that the lips cannot be loose. So if this is cut, you find that the lip become a bit loose and therefore seem to be hanging loose from the mouth. That's all about the lips. Two parts. The inner part is membrane, mucous membrane. Outer part is skin with hair. And then the middle part is known as vermilion border. Let's go in and see what happens inside the mouth. So as you can see there, when the oral fissure is open, the tongue is depressed. You can see at the back of the mouth, there's a structure that is hanging down there. That is part of the soft palate. We call that as the uvula. Then besides, we can see tonsils. So those are lingual tonsils. Lingual and pharyngeal tonsils. So these tonsils are protective organs that trap microorganisms because the mouth is considered as one of the dirtiest parts of the body because of exposure and presence of so many microorganisms at any given one time. Even now, if we do an oral swab, we'll find various microorganisms in our mouth. Something that you can see again in the mouth is teeth. Yeah, teeth are visible, both the lower and upper set of teeth, or dentition, if you like. Then if the tongue lifts up, you can see that the tongue also has its own frenulum. You call it the lingua frenulum. It holds the tongue in the floor so that the tongue is not freely mobile. So if this is cut, you find that sometimes the tongue can fall back and actually close the airway, what you call the larynx. And that person, there will be no oxygen reaching the lungs. When the tongue is lifted up, at the bottom there, besides the lingual frenulum, you can see small, small two holes there. Okay, those are opening of the submandibular gland. So if you're given food and maybe you've been hungry for some time, and then you accidentally open your mouth, you find that sometimes saliva shoots out of your mouth. It's because of these two openings found under the tongue. Or you're given a bitter fruit, for example, a lemon or something like that. Sometimes saliva shoots out from these two openings from submandibular gland. Another opening of another gland that can be seen is the parotid gland. If you check here, this is the upper set of teeth, the upper dentition. Then we have three molar tooth. First molar, second molar, and third molar. The third molar is the one at the back there. Now, at the level of the second molar, lateral to it, you find opening of the parotid gland. So it's visible. Even today, if you stand in the mirror and pull your cheek to one side, you can see that opening. That's where saliva is entering the mouth from the parotid gland. And this can be blocked sometimes. And you see that person develops swollen parotid gland. Sometimes it's a stone that forms in the parotid gland and blocks these openings. So basically, this is what we are seeing in the oral fissure. Now, let's take a deeper and more detailed view of the oral cavity. So before we discuss what is inside the mouth, we look at its function. Number one is its entrance to the digestive system. So under normal circumstances, whatever we are eating has to enter the mouth first, unless maybe there's a disease or disorder where this person cannot eat through the mouth. Then a tube can be inserted in the nose through the pharynx into the esophagus, what we call nasogastric tube. Number two, mouth is important for speech. So formation of speech, we find that the mouth, the lip, the tongue, all these organs must be moving in certain directions for us to form words. Then we have breathing. So breathing is essential also. Especially adults, you can close your nose and still breathe through the mouth. Okay. But newborn babies are obligate nasal breathers. So for them, they can't breathe using the mouth. They have to breathe using the nose until maybe around 6 months or so, or maybe 3. That's when they can breathe through the nose through the mouth as well. I explained that phenomenon when you're looking at the respiratory system, or saying a newborn baby can feed, swallow, and breathe at the same time, which you and I as adults can't manage. When you are swallowing, breathing ceases for some few seconds. So you can't swallow and breathe at the same time. Otherwise, they will be choking. Next is that the mouth is a common passage for food and air. So that is essential in an event that there is occlusion in the nose or something like that. Next is sense of gustation. So gustatory function is ability to taste food. So the tongue and the palate, here, the soft palate, has taste buds. And taste buds are able to pick the taste of food that we ingest, either salty, sour, bitter, or sweet food. Then lastly, because of saliva being an alkali solution and presence of tonsils in the mouth, this offers protection to the oral cavity. Okay. So generally, those are functions of the mouth. Okay. Needless to say, the lips, especially in the vermilion border, there are huge amounts of nerves there. So in terms of sensory function, like sensory function in the body, apart from maybe the fingers, the lips is one of the most sensitive parts of the body that we have. Of course, we can also talk about other things, but the fingers, the fingertips, and the lips. Yeah, actually, it's the lips. The lips are the most sensitive part of the human body. Okay. And that's why during development, those who do psychology, you see that at a certain age, children love putting things towards their lips. That's one way of learning for them, is to lick it, taste it, and try to understand something. Okay. Now, inside the mouth, we are saying the mouth has the boundaries. So mouth has a roof, what we call hard and soft palate. Mouth has a floor. Below the tongue there's a floor, mainly by muscles. So there are muscles below the tongue. Then mouth has the lateral walls, which are the cheeks. So in the cheeks, we have muscles called masseter muscles. So there are muscles here, masseter muscles, form the walls, the lateral walls. Then anteriorly, it is the lips. Okay, posterior to the oral cavity is the oral pharynx at the back there. Okay. So now we look at the palate. So we are starting with the roof of the mouth, which is the palate. So palate is made up of two zones. So there's hard and soft palate. I'll use this diagram here. This is mouth and tongue. You see that lower lip, upper lip. Then these are teeth. That is a lip. That is a palate above there. So anteriorly, the palate is made by bone. So that, of course, is covered by membrane inside there. So this is hard palate. Two bones make up the hard palate. We have what we call the maxillar bone and the palatine bone. I'll show them here. This part is maxilla, the one in front. This is palatine. So we are looking at the mouth from the undersurface, and this is the roof of the mouth. So that is palatine bone and maxillar bone in front. So collectively, these two bones form what we call the hard palate. They need to be covered with membrane. Okay, so all bones in the body are covered to avoid friction with soft organs. Okay. Then at the back here, you see that there is no bone. So this part will be covered with muscle and connective tissue. This is where the soft palate will be. So essentially, the palate separates the oral cavity below and nasal cavity above. So here is nose, below is mouth, separated by palate. And this is a soft palate now. So what we have there are the palatine muscles. And then what hangs below is a connective tissue known as uvula. I mentioned this to say, if you open the mouth and look at the back, there will be a structure that is seen hanging down from the mouth. That is the uvula. Okay. That is all about the palate. It's simply the roof of the mouth. Hard palate in front, soft palate posteriorly. There are certain situations that occur where the two bones fail to fuse. Okay, so palate develop as lateral bones. So one bone is developing from the left, the other bone is developing from the right. So these two must meet here at the center and close the nose from the mouth. But for some reasons, that process may fail to complete and therefore leave a gap. And therefore, there will be communication between the mouth and the nose. We call such as cleft palate, usually associated with cleft lip, where the lip also fails to fuse. Okay. So if both are present, then you call the condition as cleft lip and cleft palate. So usually goes hand in hand. And there are types now. There's unilateral cleft palate, which is on one side. Then you have bilateral cleft palate, where both sides, there will be a gap here going into one nair and a gap going into another nair there. Then we have a median cleft palate and lip, where there's a gap in the midline here. Okay. So the commonest ones are unilateral, where it is one side. Okay. So we look at the floor of the mouth. So in the floor of the mouth, we said there are two muscles, but before we look at that, let's look at the tongue itself. So the tongue is nothing but a muscular structure surrounded by epithelial tissue. So the covering of the tongue is stratified squamous epithelium. Then underneath there, we have skeletal muscles. So muscles in the tongue are skeletal, and therefore we have conscious control over the tongue. Whatever you speak, whatever you say, is because that's what you want to say. Okay. Let's look at parts of the tongue. So the tongue has an apex. This is the anterior part. It is a bit sharper or narrower than other parts of the tongue. Then we have the body now. So the whole lot of this is a body, ending at this V-shaped structure. Okay. So these are sets of lingual papilla. You can see those making more like a V-shaped structure, like that. This is where the body of the tongue ends. Then at the back is a root, or what you can say the origin of the tongue. I want you to observe that at the origin of the tongue, there are so many tonsils there. We have the lingual tonsils in the sides. We have the palatine tonsils. These are palatine tonsils, then these are lingual tonsils. All of these are helping to fight off any infection before we swallow whatever is in the mouth. Then again, we see that the root of the tongue is connected to the epiglottis. So that is epiglottis. Okay. So root, body, and apex. Then again, observe that in the mid part of the tongue, there's a cleft here. So we call that as a median sulcus or groove of the tongue. So equally, the tongue develops as two separate entities, then they meet in the midline. Equally, disorders can occur where the two parts don't meet. So you have a forked tongue, where the tongue seems to split in half, like a tongue of a snake or something like that. There are certain babies who are born like that. Okay, of course, that would be scary to the mother. And in our setup in Africa, we may think this child has been bewitched, or the mother was bewitched while pregnant, or maybe a child born from a witch, such kind of things. But you and I, who are in the medical field, should be able to explain that such disorders can occur, and it shouldn't be misled for witchcraft or any other issues. Another structure I want you to focus on is this cleft here, known as foramen cecum. Foramen cecum is a small depression at the root of our tongue there. All of us we have. And if you're the two of you, you can examine each other. You let the person protrude their tongue, and then you examine it with a torch. You see a small depression. What happens is that there's an organ that develops from the tongue here. When the tongue is developing, another organ develops from the tongue and sinks from the surface of the tongue, goes deeper into the tongue, and lives under the tongue there to migrate into the neck. Okay, that organ is the thyroid gland. The thyroid gland, you've heard of goiters, when the thyroid gland overgrows. So partly develops from here, then sinks through the tongue and goes to the neck region. So that's where the thyroid gland originates from and leaves that mark there, what we call foramen cecum. Okay. Now let's look at the surface of the tongue and see if there are any special things that we can see. Already you can see more like bumps or roughened structures. We call those as papillae. Then besides the tongue also you can see those lines. Those are still papillae. So different papillae have been identified on the tongue. So papillae, they are more like roughened structures on the tongue. So if you zoom in on the tongue, you see that they are of different shapes. Number one, we have the filiform papillae. You see those? So these are the most numerous type of papillae. Majority of the tongue, you find these papillae. And these papillae can be covered with keratin. So sometimes if you look at the tongue, you see grayish spots. That is keratin. So it's not the entire tongue that has non-stratified squamous epithelium. Parts of the tongue will have stratified squamous epithelium with keratin, especially on the filiform papillae. But if you just say the tongue is stratified squamous epithelium non-keratinized, you still get all the full marks. So those are the filiform papillae, the most abundant. Then the others are fungiform. Now, fungiform are termed as such because they resemble a mushroom. So fungi, that's where the name was gotten from. So they are broad at the apex and narrow at the bottom. Then we also have what we call valate. So these are the valate papillae, the largest papillae on the tongue, and they form this structure here. You see that? And this is where you say the body ends, the body of the tongue ends. Behind the valate papillae is the root of the tongue. So they form this V-shaped structure. All these are valate papillae. Okay, about 12 or so, they form that V-shaped structure, the largest papilla on the tongue. Then the last are these by the sides, which we call foliate papillae. So valate, they are there, about 12 or so. Foliate, they are besides the tongue. Now, out of these 4 types of papillae, we are saying it is only the filiform papillae that do not have taste buds. So you see, in the undersurface here, not at the top, the taste buds are not papillae. So let's not confuse the two. Taste buds are different from papillae. Papillae are simply bumps on the surface of the tongue. Then these bumps in their sides, that's where you find taste buds. These whitish substance we are seeing here, those are taste buds. So all of these papillae have taste buds except the filiform papillae. Okay. So let's look at those taste buds. So what is a taste bud? Taste bud is nothing but a sensory organ found on the tongue. It is responsible to differentiate different type of molecules contained in food, and therefore we'll be able to know whether what we're eating is sour, bitter, or sweet. So in the taste bud, there are 3 types of cells that make up a taste bud. Number 1 are the basal cells. Look at those round cells here. 1, 2. These cells are found at the bottom of a taste bud. So they are called basal cells. What is their function? Their function is to act as stem cells. Stem cells, these are cells that can replace other cells. So they have not yet specialized. They are waiting. Think of them like someone who has left high school. That person can be turned into anything. Can be a doctor, can be a nurse, can be a lawyer, can be something. So we call those as a stem cell. Then the other 2 types of cells found in a taste bud are now the support cell. So support cells are the cells that are protecting now the actual cells that taste the food that we eat. We call them as sensory cells. So these are the sensory or gustatory cells. So what is protecting them are support cells. So in an event that the gustatory cells and the support cells are damaged, we depend on the basal cells to replace those dying cells. Now observe that all the sensory cells are connected to nerves. So these cells themselves are nerve cells. And then they have axons, which form now the nerves that go to the brain as cranial nerve number 2, or what we call the gustatory nerve. Okay. Sorry, not cranial nerve number 2. This is hypoglossal, yeah. This will form part of hypoglossal nerve, not cranial nerve number 2. So this is a structure of a taste bud, and you must know the type of cells found there: basal cells, support cells, and sensory or gustatory cells. What is the function? You must to know. Gustatory cells are responsible to taste the food. Support cells support or protect the gustatory cell. That is both physically and metabolically. Then basal cells are stem cells. So that is it about the tongue and the papillae found there. Of the papillae, special note is given to the foliate here. So the foliate papillae, we are saying foliate papillae are found mainly in young persons. So if you check yourselves as adults, you find that you're going to have very few foliate papillae here. So as we age, the foliate papillae reduce. For some, you may not even see them. But if you look at the tongue of a young person, you see they are going to have a lot of lines besides here. Those are foliate papillae. Now, foliate papillae are numerous in herbivores, animals that eat grass, like cattle, goat, sheep, and the rest. Because for them, they don't have hands to pick the grass and put in the mouth. So they depend on the tongue to hold the grass and cut it with their teeth. So they need something on their tongue that can do that. So they have more foliate and well-developed foliate papillae than human beings. Now, you and I, of course, we can eat grass in the form of vegetables, but we don't depend on the tongue to hold them. We have hands to put food in our mouth. So that's why they're not well developed. Finally, we finish on the tongue. So what type of muscles are there? So you see that on the surface, yes, it is stratified squamous epithelium, and there are these bumps or spots, what we call papillae. And then we have submucosa. Then we have muscle now. So let's look at the muscles in the tongue. Before we even look at that, look at the glands there. So the tongue also has glands, what we call von Ebner's glands. Von Ebner's glands. These are glands found in the tongue itself. And they help to provide a watery environment where molecules can dissolve on the tongue and we're able to taste it, in addition to saliva. So let's look at the muscles now. So there are two sets of muscles found in the tongue. Remember, I was saying the whole tongue is made up of skeletal muscle. So there are those muscles that are found within the tongue. Then we have those muscles that are entering into the tongue. So those muscles that are found in the tongue, we call them intrinsic muscles. Intrinsic meaning inside. Then we have muscles that are entering into the tongue from elsewhere around the mouth. We call those as extrinsic muscles of the tongue. So we start with intrinsic. So intrinsic, there are three types. So we have longitudinal muscles, we have transverse muscles, and vertical muscles of the tongue. So let's begin with the longitudinal one. So longitudinal, these are muscles that are going in the direction of the tongue. So they are going back and forth, back and forth. So they're going from front to back, or back to front, if you like. So they are following that length of the tongue. So there are those that are found in the superior aspect here. So we call those as superior longitudinal muscles of the tongue. Then there are those in the lower half of the tongue. We call them inferior longitudinal muscles of the tongue. Then we have the transverse ones. So transverse ones are cutting across. So from left to right, left to right. These are the muscles here. So we call those as transverse muscles of the tongue. Then we have the vertical ones. Now, vertical ones are running up and down, up and down. So those are the vertical muscles of the tongue. When these muscles of the tongue are used, you find that they alter the shape of the tongue. So when we are speaking, the tongue is thrown in different directions, and therefore each shape is changing to form a particular word or particular pronunciation. So in short, these muscles, the intrinsic muscles, these are muscles that are found within the tongue. They are muscles of speech, or they simply alter the shape of the tongue. So for example, depression of the tongue, retraction of the tongue, elevation of the tongue, all that is intrinsic muscle. Let's look at extrinsic. Now, extrinsic muscles, these are muscles that are originating elsewhere, but they are entering in the tongue. So they are given two names. One name signifies where the muscle is coming from. So the first part of the name tells us where the muscle is coming from. The last part tells us where the muscle is going. So you see that all these muscles have glossus. Glossus means tongue. Whenever you hear gloss or whatever, that is to do with the tongue. So we have palatoglossus muscle. So palatoglossus, these are muscles that are originating from the palatine bone to go into the tongue. So we call it palatogrosso muscle, from the palate to the tongue. Then we have genioglossus. Here, this is the lower jaw, what we call the mandible. Inside the mandible there are small bone protuberances, these projections here. We call them as geniotubercles. Geniotubercles. So there's this muscle. You can see that this wide muscle is starting from the geniotubercle of the mandible to go into the tongue. So we call this muscle as genioglossus. Genioglossus. Then we have hyoglossus. There's a hyoid bone, which is found superior to the larynx. This is the larynx. That is the hyoid bone. So there's this muscle here, starting from the hyoid bone to go into the tongue. So we call this muscle as hyoglossus muscle. The last one is the styloid process. So if you touch your earlobe, the lower part of the earlobe, then below that, there's this depression behind the jaw. That's where there's a sharp bone known as a styloid process. There's a muscle that comes from there to go into the tongue, this muscle here. So that muscle is called styloglossus. What is the function of these all muscles, which are originating elsewhere but going into the tongue? These muscles make the tongue to protrude out of the mouth and pull the tongue back into the mouth. So these are muscles that are helpful in swallowing. Remember, the intrinsic muscles are for speech, but for swallowing, we use extrinsic muscles. So remove your tongue from the mouth, you're using these muscles. Pull back the tongue into the mouth, you're using extrinsic muscles of the tongue. Then there are these movements now, which you can read on your own. Applied anatomy to the tongue mainly is a condition known as ankylosing. This is common. Ankylosing is also known as tongue tie. This is a baby born with a short lingual frenulum. You can see this baby here. That membrane is too short. So movement of the tongue is restricted here. And this child may have difficulties speaking. So that membrane has to be cut to allow the tongue to freely move. Okay. Then other conditions that may affect the tongue is what we call macroglossia. This is where the tongue is too large for the mouth. This is seen in patients with acromegaly. When you reach a certain age, above 25 years of age, then for some reason, maybe there's a tumor in the pituitary gland. Then the gland starts to produce excessive amounts of growth hormone. Now, at that stage, the skeleton cannot grow any further. So people with acromegaly, what you see is changes in the facial features. The face becomes overly large. You can see some abnormality. The jaw will be too big, and the tongue also will be so big. So that is called macroglossia. or it can be a cancer. The tongue is having some cells within the muscles that are growing abnormally, so the tongue becomes too big. Then otherwise, we can also have microglossia, where the tongue is too small. Very rare conditions, but ankylosing, when you go to the PEDS wards, even here at UTH, you can find such babies born with a tongue tie. So for now, we can end here. As usual, if there are any questions, I'll be at your service. Just let me know. We can explain further.